I am going to be covering your shock lecture. I know Ms. Fleming has covered septic shock with you guys, and so we're going to cover all of the other shocks. Alright, so shock is not a specific disease. Shock happens because of something else that occurs in the body. So if somebody's a trauma patient, they have a lot of blood loss, say they have a femur or pelvic fracture, and those are going to cause a lot of blood to be lost. They're probably going to go into hypovolemic shock, but that hypovolemic shock is caused by that trauma and those fractures. So shock it happens because of a primary issue. It is secondary. And it is not as simple as just hypotension. It's not, oh, we're just hypotensive, we just have to fix the hypotension. No. It can become a systemic problem, and we're going to talk about that. But it's not just a simple state of hypotension. So technically, it is a clinical condition that is characterized by that inadequate tissue perfusion. So shock can result from that ineffective cardiac function, which is ultimately going to be like a cardiogenic shock type situation. That inadequate blood volume, that's going to be that hypovolemic shock, or inadequate vascular tone, which is going to be more of like a obstructive type shock. So shock is not isolated to just one organ system. Instead, it can be that it can affect your entire body, and that's going to be our distributive shock piece. So our distributive shock can be subdivided into three other categories. We can have septic shock, we can have anaphylactic shock, and we can have neurogenic shock. If we do not correct shock, it can progress to organ failure and death. So with it being a clinical condition that is characterized by inadequate tissue perfusion, if we're not perfusing things like we need to, we're not getting blood flow and oxygen to our vital organs, we can see how that can really quickly become a problem and lead to organ failure and death. You know, if our brain, our kidneys, our heart, things like that are not being adequately perfused, we're going to have problems in the long run. All right, so some variables that can affect our oxygen transport. If we have a lot of blood loss, it's going to affect our circulating blood volume that's going to be able to carry oxygen on that hemoglobin. If we have an increase in cardiac output, that's going to ultimately help us with our oxygen transport. If our oxygen demands exceed our oxygen supply, that's also going to become a problem. If we start having shifts in the oxyhemoglobin dissociation curve, we're going to have problems, and that can ultimately cause anaerobic metabolism as a result. And then shock usually begins with a failure from the cardiovascular system in at least one of four components. So we can either have blood volume that's lost, we can have issues with myocardial contractility, blood flow, or vascular resistance. So normally our body is homeostatic, we have homeostasis that is maintained, but then something fails and we start compensating. Then we have a compensatory mechanism that fails and shock occurs. Because even though we can compensate, kind of like I talked the other day with our neuro lecturer and Monroe Kelly, we can compensate for a little while, but eventually we're gonna that compensatory mechanism is gonna fail. And we're going to have a crashing patient on our hands. Okay, so just some quick definitions of what shock is. So we have hypovolemic shock, which is an inadequate intravascular blood volume. We have cardiogenic shock, which is when our heart fails to act as an effective pump. We have obstructive shock, which is physical impairment to adequate circulating blood flow. And distributive shock. So distributive shock is going to be a widespread vasodilation and decreased vascular tone that results in hypovolemia. So like I said, distributive shock is going to include that neurogenic shock, anaphylactic shock, and septic shock. Shock is not selective in how it affects, or what it affects. So all cells, all tissues, and all organ systems can suffer from the physiologic and stress of shock, from the physiologic effects and the stress of shock. And that's going to cause decreased tissue perfusion. So it ends an organ dysfunction. The end result of shock, if it's not corrected, is going to end an organ dysfunction because of a decreased blood flow through our capillaries that supplies our oxygen and nutrients to our cells. Just going to reiterate quick review of our circulatory system, so because this is kind of important when it comes to shock. So obviously the volume of fluid that we have is going to play a big part in how shock affects us. The strength of the pump, aka our heart, if it's not very strong, we're going to have problems and can lead to shock. And then our vessels, so the size and the integrity of our pipes. So if we start having very stenotic, very flimsy vessels, we kind of start running the risk of things like obstructive shock or things like that, where those vessels are just going to get blocked, and it could be a major, artery or something that delivers blood flow. And if we're not perfusing where we need to perfuse, we can very easily end up in shock. Some quick definitions. You guys have probably learned about these, but I just want to go through them again real quick. So we've got cardiac output, which is the amount of blood that is pumped by the heart each minute. We've got our heart rate, which is our beats per minute. Stroke volume is the amount of blood ejected by the ventricles each time our heart beats. We've got preload, which is the volume in the ventricle at the end of diastole. We've got afterload, which is the resistance to ejection. And we've got contractility, which is that myocardial fiber shortening. Okay, so quick physiology of shock. So I know we've talked a lot about MAP. So MAP is our mean arterial pressure, and MAP reflects organ perfusion. So if our MAP starts getting too low, we as healthcare providers know that our organs aren't being perfused like they need to be. Most of the time, MAP is, providers, and especially in critical care, are going to want your MAP 60 to 65 or greater. At least 60. 60 is the minimum cutoff that I have seen. I think one hospital here wants 60 and the other is okay with 65. But 60, 65, somewhere in that range is usually where they want you to keep your MAP at. So what influences MAP? Obviously, total blood volume, our cardiac function, the size of our vascular bed, and then our sympathetic tone. So we're kind of starting to see a pattern here. These things we're kind of repeating. Okay. So now we are going to talk about our 4 phases of shock. We've got the initiation phase, compensatory phase, progressive phase, and irreversible phase. So the initiation phase is initiated by subclinical hypoperfusion, and it's caused by an inadequate oxygen or inadequate extraction of oxygen, or both. At this point, we're probably not really going to see a whole lot of clinical signs and symptoms that are obvious, but if our patient is on like invasive hemodynamic monitoring, we are probably going to maybe note a decrease in cardiac output. For the compensatory stage, our body starts compensating, and we've got 3 different areas that our body starts compensating in. We've got the neural compensation, we've got endocrine compensation, and we've got chemical compensation. So the whole compensatory stage in general happens because of a sustained reduction to our tissues. So perfusion, sustained reduction of perfusion to our tissues. So this, in turn, causes that compensatory mechanism or a compensatory mechanism to kick in because we have a sustained decrease in blood flow. So at this point, we can still reverse the phase of shock, but we have to be very proactive with it and aggressive with our interventions. So for neural compensation, we've got baroreceptors and chemoreceptors that we're going to see kind of start to be able to pick up on things, and it's going to help release epi and norepi to drive up our blood pressures. Our heart rate and cardiac contractility is going to start to hopefully improve because catecholamines are going to be released. We're going to have systemic vasoconstriction and redistribution of blood. And then we're going to have that arterial vasoconstriction that's going to improve our blood pressure. And venous vasoconstriction is going to augment that venous return to the blood. So that's going to help increase our preload and cardiac output. Blood at this point is going to be shunted from our kidneys, our GI tract, our skin. It's going to be shunted to places that are vital that need them. So we're going to be thinking heart and brain. Got to have heart, got to have a brain to function and be alive. The additional catecholamine effects can also include an increased blood glucose levels, or an increase in blood glucose levels, because our liver is going to be stimulated and it's going to convert glycogen to glucose for energy. We're also going to probably see some dilation of pupils, peripheral vasoconstriction, and we're going to start seeing an increased sweat gland activity. And that's going to help keep our skin cool and moist. So it's going to try to help regulate out our body temperature. For endocrine compensation, we have got, this is a response to the reduction in the blood pressure, and we're going to have messages that are being sent to our hypothalamus that's going to help stimulate the anterior and the posterior pituitary glands. So when that anterior pituitary gland is stimulated, it's going to release that ACTH. That ACTH is going to act on those adrenal cortexes to help release those glucocorticoids and those mineralocorticoids and glucocorticoids, which we also know as aldosterone. So those glucocorticoids are going to help increase blood glucose by increasing the conversion of that glycogen to glucose, and then it's going to cause conversion of fat and protein to glucose. Whereas our mineralocorticoids are going to act on those renal tubules, and it's going to help increase our reabsorption of sodium and water, which is going to increase intravascular volume and blood pressure. So I know you guys have probably talked about the renin-angiotensin aldosterone system. So that's going to kind of play a key piece here when we're talking about the compensatory phase of shock, specifically with our endocrine compensation. So that renin-angiotensin system is going to be stimulated, and that is going to reduce the pressure in the renal arterioles, which is going to then decrease sodium levels, and they're sensed in the kidneys. So when we have that decrease in renal perfusion, those juxtaglomerular apparatuses in our kidneys is what's going to release that renin. So renin is going to circulate in the blood, and it's going to react with that angiotensin to produce that angiotensin 1. Angiotensin 1 is then going to circulate through our body and go to our lungs, and it's going to form that angiotensin 2. So that is going to create a potent arterial and venous vasoconstrictor that increases our blood pressure and is going to help improve that venous return to our heart. Angiotensin 2 is also going to help activate the adrenal cortex to release aldosterone. We then have ADH, that antidiuretic hormone, and it's going to be released by our posterior pituitary gland, and it's going to be in response to an increased osmolality of our blood that occurs from the shock. So the overall effect really of the endocrine compensation is to help combat shock by providing the body with glucose for energy, and that's going to help increase the intravascular blood volume. All right, and then our chemical compensation for our compensatory phase is we're going to see our pulmonary blood flow is starting to be reduced, and then because of that, we're going to see those ventilation perfusion imbalances. So initially, when our alveolar ventilation is adequate, but the perfusion of blood through the alveolar capillary bed is going to become decreased. So we've got adequate alveolar ventilation, but the perfusion of blood through the alveolar capillary bed is going to be decreased. So our chemoreceptors in our aorta and our carotid arteries are going to be stimulated. They're going to say, hey, and then in response to that, we're going to have low oxygen tension in the blood. So consequently, this is going to cause an increase in our respirations. The rate and the depth are going to change. And it very likely is to cause some hyperventilation, which is going to cause carbon dioxide to be excreted, and that's going to result in respiratory alkalosis. So a reduction in that carbon dioxide levels in that alkalotic state is going to cause vasoconstriction for our cerebral blood vessels. So this, coupled with a reduced oxygen tension, vasoconstriction can lead to cerebral hypoxia and ischemia. So the overall effects of chemical compensation is to result in an attempt to combat shock by increasing oxygen supply, but it may also cause cerebral perfusion to become decreased. Okay, so then we move into the progressive phase of shock. So the progressive phase of shock is pretty much exactly how it sounds. So we start having a progressive phase when shock goes, that hypoperfusion side of shock goes uncorrected, and we start getting to the point where we're going to have a harder time trying to reverse the effects of shock. So the vasoconstriction in this phase is going to continue in the systemic circulation. So even though this affects and shunts blood to the vital organs, we're going to have a decreased blood flow that's going to lead to ischemia in the extremities. So this is where we're going to start to see our weak or absent pulses and our altered body defenses. We're going to have prolonged vasoconstriction. It's going to result in that decreased capillary blood flow, and it's going to cause cellular hypoxia. So this is when we're going to start seeing maybe the limbs, our fingers, our toes, our legs, our arms are going to become dusky, they're going to be blue, and it's because we're shunting everything to our heart and our brain, trying to keep the body alive, and the limbs, the extremities are not vital to our life and being able to live. Okay, and then the irreversible stage or refractory stage is also known here. So at this point, we've had prolonged inadequate tissue perfusion, and it is unresponsive to the therapies that we have tried, and this is ultimately going to lead to that multiple organ dysfunction and death. So we have a large volume of blood that's going to remain pulled in our capillary beds, and the arterial blood pressure is going to be way too low to support perfusion of the vital organs. So at this point, we're going to see patients who are on probably every pressor in the book, plus some. You know, at this point, we're going to be maxed out on anything and everything that we can be, and it's just not working. This is the point where, you know, we need to be looking and talking about code statuses and things like that, and what the family does and doesn't want done, because at this point, we've thrown everything we probably can at them, and we're just not getting anywhere. Okay, so this is ultimately these stages are ultimately going to lead to acidosis. So when we have an inadequate oxygen delivery, we have cellular extraction and consumption that result in cellular conversion to that anaerobic metabolism for energy. You know, ATP starts being produced. We're going to have an increased production of a release of lactate. So we're going to start seeing our lactic acid levels become really, really high. We're going to start seeing signs and symptoms of probably, you know, that prolonged shock, that progressive shock start to set in. And at this point, if our lactic is too high, that can become very, very problematic for our patients. Okay, so I've kind of already gone over this, but just going to kind of reiterate. So our vascular response is usually going to occur immediately. We're going to have that peripheral vasoconstriction. Those arterioles are going to constrict to increase our total peripheral resistance, and then we're going to see some venous system vasoconstricting as well. So remember those chemoreceptors, they're real sensitive. They're sensitive to low levels of oxygen and excess levels of CO2 or carbon dioxide. So they're going to be activated when that arterial blood pressure starts dropping below 80. And then we've got our cerebral response. So our blood flow to major organs is preserved. So remember that shunting of the blood. So our brain and our heart are going to be the things that need the blood the most. So everything else is going to be kind of put on the back burner, because without adequate blood flow to our heart and our brain, we're not going to be able to sustain life. If we start getting ischemia to those things, we're going to be having major problems. So our blood pressure, when it starts dropping below 50, that's when we start seeing cerebral ischemia happen. So this is really important, or this is why it's really important to keep our maps and stuff up into an adequate level, because when we start dropping, we're not perfusing the way that we need to be. Okay, and so I kind of already talked about the renal ischemia. So we've got ischemia, and then renin is going to be released from those juxtaglomerular cells, which is then going to cause renin to be released in plasma, and then we can see how all of that goes. I kind of already talked about this in depth. This is just a diagram that I left in here for you guys, just in case you wanted to review it. Okay, so remember that adrenal response is also going to increase that release of catecholamines, and then our cortisol is going to be released from those adrenal glands. And then that hepatic response, that glycogenolysis is going to be activated by epinephrine, and then that blood flow is going to be redirected to those other vital areas through that hepatic vasoconstriction. Okay, so one thing I haven't really talked about yet is the hematological side of things when it comes to shock. So the interaction between inflammation and coagulation, it enhances clotting and it inhibits fibrinolysis. So this is going to lead to clotting in the microcirculatory system as well as bleeding. So we've got an increased consumption of platelets and clotting factors that happens, and this causes coagulopathy to become more prominent and more evident. So since our liver is not able to manufacture the clotting factors at this point, remember everything that's happening in our body whenever shock starts to set in. We go through prolonged clotting times. So therein lies why we start having problems with clotting, and we very well may go into things like DIC, that disseminated intravascular coagulation. We can see things like petechiae and ecchymosis that can happen. We also may start seeing blood in the urine, in the stool, when we start aspirating like gastric contents, and then maybe even in our tracheal secretions, if they've got an ET tube and we're suctioning them. So clotting in the microcirculation is going to cause peripheral ischemia, and that's going to be manifested by cyanosis, like, bluing and dusky looking extremities. Hands, face, feet, necrosis can even set in with our digits and extremities. I kind of talked about that a little bit earlier. And then we have leukocytosis that can frequently occur. So this is especially prominent in early septic shock. And then leukopenia can occur later because of the consumption of the white blood cells that happens. And then I kind of already hit a little bit on the pulmonary response. So, we can have those acid-base imbalances. We can have an increased oxygen supply. We're going to have tachypnea. Our rate and depths are going to change, and things like that. So I do want to throw in here that we have a shock pitfall. So just because you have an isolated head injury, that is not going to automatically cause shock, and that is a common misconception. So I just wanted to throw that in there so that you guys are aware of that. Isolated head injuries do not cause shock. Okay, so next we're going to talk about recognizing shock and management of shock. So we want to recognize its presence. We want to identify probable causes. We want to restore perfusion. reevaluate the patient's response, and then we want to have a definitive treatment plan. So these are the steps we're going to have to take, or we need to take, if we want to be able to ensure that our patient has the best chance of survival and that we are, being as proactive as possible. Okay, so now we're going to start talking about the other types of shock, our hypovolemic shocks and things like that. Okay, so remember, hypovolemic shock is a decrease in the circulating blood volume. So this is going to be from massive blood loss. This is the most common form of shock. You can have fractures, you can have a trauma accident, some kind of bleed. We've just had a massive loss of circulating blood volume. So this results from whole blood loss from hemorrhage, and then leakage of plasma and proteins from the intravascular space when cell membrane integrity is impaired. Some clinical signs and symptoms of shock include that loss of consciousness. We can also have some agitation. Our skin's going to be cool, pale. We're going to have delayed cap refills. Greater than 4 seconds, we're going to have delayed cap refills. We're going to see tachycardia happen. We're going to see a decrease in urinary output. But it's important to note that just because you have a decrease in urinary output, it is not a reliable endpoint for resuscitation of shock. And we're gonna talk about that here in just a little bit. But I do want to make sure that I mention that, just because we are going to fluid resuscitate these patients. But just because they're adequately, putting out enough fluid or not putting out enough fluid doesn't mean that urine output is a reliable endpoint for resuscitation when it comes to shock patients. We're also going to see narrow pulse pressures when it comes to these patients, and that is just them compensating for tissue perfusion. We're going to see that systolic drop, but we're probably going to see that diastolic stay the same or similar to what it has been, but that pulse pressure, those numbers, that systolic and diastolic, the amount between them is going to become more narrow, and that systolic is going to be the number that drops. And it's just a compensation measure. And then we can have a labile or decreased blood pressure. So just like I said, that systolic is probably going to drop at this point, and it's what's going to cause that narrow pulse pressure. Okay, so then we have hemorrhagic shock. So hemorrhagic shock is caused by blood loss or other fluid loss from soft tissues. We have compensatory mechanisms. It's going to be tachycardia, helping pump as much blood out as we can. We're going to have an increased peripheral vascular resistance. So we're going to shunt blood away from those non-essential organs, and we're going to push it towards our heart and our brain that we've got to be able to keep alive and keep going in order for our patients to sustain life. This table is going to be really, really important for you guys. So we have different classes. We've got 1, 2, 3, and 4 of shock. So we have how much blood loss we have what our pulse should be, the percent of blood volume that's lost, systolic, pulse pressure, our respiratory rate, and then our CNS. So with like class 1, it's going to be less than 750 mils of volume loss, or less than 15% total loss of blood volume. Our pulse should still be less than 100. Our blood pressure systolically is probably still going to be normal. Pulse pressure should be normal. Our respiratory rate's still going to be normal, but they may be a little bit anxious. So we move to class 2. We've got 750 to 1500 mils of blood loss, which is 15 to 30%. Our pulse is probably going to be a little bit above 100 at this point. Systolic blood pressure should still be about normal. Pulse pressure, this is where we're going to start seeing a decrease in that pulse pressure. And then our respiratory rate is going to be 20 to 30 ish, and we're still probably going to have a little bit of anxiousness on our hands. That class 3 is going to be 1.5 liters to 2 liters, so 1,500 to 2,000 mils of blood, which is 30 to 40%. of our total blood volume. Pulse is going to be greater than 120. Our systolic blood pressure is now going to start decreasing. That pulse pressure is going to start decreasing. Our respiratory rate is going to keep driving up. And then our CNS, we're probably going to start seeing some confusion. And then class 4 is greater than 2,000 mils or 2 liters of total blood loss. The percent volume is 40% or greater. Our pulse is going to be pretty tacky. We're going to be 140 and up. We're still going to have a decreased systolic blood pressure. That pulse pressure is still going to be decreased. Our respiratory rate is still going to just keep driving up, and then we're going to become lethargic in this stage. Okay, and I just have this in here for you guys. I know I've mentioned femur fractures and pelvis fractures. As we can see, these are the biggest issues because they can cause the most bleeding. So if we think about how vascular those areas are, how big those bones are, how much blood they, have in them, and how just a fracture of that magnitude can cause problems. This is the amount of blood that they can literally lose from those fractures. So pelvis fractures, we can lose anywhere from 750 to 6,000 mils of blood, and then femur fractures, we can lose anywhere from 500 to 3,000. My brother broke his femur. Thankfully, he was good, but I remember my mom, who is the ortho person, was freaking out. Thankfully, it was a closed fracture and nothing was super crazy with it, but she was freaking out because from an ortho standpoint, she very much knew how much blood loss can occur from those types of fractures. Okay, so for our clinical assessment, we are going to want to be looking at the patient's level of consciousness, their pulse pressure, what their heart rate or their pulse is, their respirations, their blood pressure, their skin, and their temperature. Those are going to be our big assessment pieces here for evaluating these shock patients. Oops. So for level of consciousness, this is an early sign of poor tissue perfusion. So we start seeing a decrease in that level of consciousness. This is going to be an early sign of that poor tissue perfusion for these hypovolemic shock patients. So this may also be the first sign of septic shock. This is just going to be a very, very indicative and important thing to be looking for. Sometimes it can be difficult to differentiate between impending DTs and sepsis. So it's just going to kind of depend on the situation, but we do need to be evaluating our patients. Okay, so next we're going to talk about pulse pressure. So pulse pressure, like I've told you guys before, it's that difference between the systolic and the diastolic blood pressures. So a normal pulse pressure is about 40. This also is reflective of stroke volume, and it's more accurate. It's a more accurate reflection of blood flow than a systolic blood pressure. So we're going to start seeing a narrowed or a decrease in pulse pressure with our hypovolemic and cardiogenic shock patients. We start seeing a widened pulse pressure with septic shock and increased intracranial pressure. So just like I told you guys with our neuro lecture, we start seeing wide pulse pressures with increased ICPs. It's the same, but we also see it in septic shock patients. So our pulse, tachycardia is the first response in children and adults to hypoxemia. So if our oxygen levels start dropping, we're probably going to start seeing that tachycardia start to set in. But remember, we can only compensate for so long. Tachycardia is, we start getting tachy, we're starting to pump out blood flow, helping increase those oxygen levels, because oxygen, once again, is carried on hemoglobin. So we're trying to compensate here. As soon as that starts happening, or that becomes too much, remember those compensatory mechanisms are eventually going to fail. So bradycardia is soon going to follow. Bradycardia in a distressed patient is an ominous sign of impending cardiac arrest. When you have a patient that becomes stupid tachycardic and then all of a sudden just boom bottoms and becomes super, super Brady, we have got problems and you better get the crash cart. So respiratory arrest usually happens, and then cardiac arrest will also follow as soon as that happens. You usually have one with the other. So with our respirations in early shock patients, we're going to see that increased rate, or that tachypnea, and that increased depth, just like I mentioned earlier. In late shock patients, we are going to see patients who are hypoventilating, so they're not getting enough oxygen, they're not breathing enough, our respirations are become really shallow, and then we eventually go into respiratory arrest and go apneic. And at this point, we have to intubate. So, blood pressure. Key point. Shock is a problem of decreasing tissue perfusion, not a decreasing blood pressure. Remember what I said at the beginning of this lecture. Hypotension, shock is not as simple as hypotension. It's a much, much bigger issue and much bigger problem. So, shock is a problem with tissue perfusion. And like I said, hypotension will typically occur with that, but it's not as simple as just having a patient with low blood pressure. All right. So in adults, our systolic BP does not start dropping until we've lost about 30% of our blood volume. In kiddos, they're a lot more resilient than we are as adults, so they don't start dropping their systolic until about 40 to 45% of their blood volume is lost. So we can see how in peds, it's going to be a lot easier for us to miss things because they're going to require more blood loss before we start seeing effects on their blood pressures. So we can't always rely on our blood pressures because remember, hypotension is not, it's not just a hypotension issue. This is a whole body issue, and we have to look at the big picture here. So initially, we're going to have that narrow pulse pressure. Later, that diastolic is going to start dropping, and it's eventually just going to become unmeasurable. So we're going to start seeing problems with not being able to get blood pressures. If they have an A line, it's going to be, or an arterial line, it's going to become very flat. It's going to become very, very low numbers. Sometimes I've even been like, oh my gosh, is that like leveled right? And then it's like, holy cow, yeah, it is. Like we have very much progressed into the late stages of shock. And then at that point, we're just trying to recon and see what we can fix. So with neck veins, these, and I know you guys have talked and learned a lot about neck veins, so these are going to be reflective of our venous return. So if they're very flat, we're hypovolemic, we don't have a lot of volume, but if they're distended, that means we're overloaded. Think back to like your heart failure patients. They typically have those bigger neck veins, those distended neck veins. Distended neck veins in shock patients can be indicative of pericardial tamponades or tension pneumos. So it's really important to be aware of those as well. When we're thinking about temperature, hypothermia is super common in traumatic hypovolemic shock patients. And if you think about that, they've lost all this blood or all this fluid. And with that, it's going to cause a major change in the temperature of their bodies. So hypothermia is then we're going to be at risk for causing major coagulopathy. So they're going to be at risk for clotting. Acidosis can become an issue. We're going to start probably seeing arrhythmias. And then we're going to see decreased liver metabolisms. So temperature can be either low or high in sepsis, but with hypovolemic shock, hypothermia is probably going to be the thing that you see the most. We see a lot of the time these patients get like maybe warmed crystalloid fluids like normal saline or things like that. We warm these fluids to try to help warm their body back up, because if they become too hypothermic, it's going to be very, very problematic. Their body's not going to be able to regulate. It's not going to be able to get the energy it needs. It's just going to create a catapult and a cascade of problems. So hypovolemia and hypothermia, I really need you guys to remember that hypovolemia and hypothermia increase the risk for blood coagulopathies. These patients are going to be very, very, very high risk for coagulopathies. Okay, so we're going to talk about neurogenic shock for just a second. So neurogenic shock is a nerve impulse problem. So it's going to be loss of vasoconstrictor or sympathetic activity. It's going to lead ultimately to vascular collapse. So we've got a loss of vasomotor control that leads to vasodilation, and then a depression of the central nervous system that is due to spinal cord injuries or high cervical lesions of the sympathetic pathways. So in these patients, they're going to present with sustained hypotension, bradycardia, and warm, dry skin. They're going to have decreased systemic vascular resistance. They're going to have decreased central venous pressures. Their pulmonary and capillary wedge pressures are going to be low, and hypothermia may happen because of the impaired thermoregulation. Think about your spinal cord or your cervical column. If you start having injuries to those, depending on where that injury is, it's going to depend on what signs and symptoms that patient starts having problems with, or those clinical signs and symptoms that we see because of the problems that the patient's enduring. So cardiogenic shock is a pump problem. So our heart, if it becomes too weak, isn't able to pump out the blood that our body needs. So this is that decreased cardiac perfusion, which is going to result in that decreased circulating blood volume. With these patients, we can see pale, cool, and clammy skin, tachycardia, tachypnea, that narrowed pulse pressure, a decreased pulse pressure, or a decreased blood pressure, an increase in their pulmonary artery wedge pressures, weak or absent peripheral pulses, anxiety and restlessness. We're going to see those distended neck veins. Remember, we're going to have a backup because the heart's not strong enough to pump things out, just like heart failure. We're going to see peripheral edema, pulmonary edema, and then a decrease in urine output. So we manage cardiogenic shock. We can do it a couple of different ways, mechanical or pharmacological. So with pharmacological, we want to decrease the preload. So we give diuretics and we give vasodilators. We want to decrease that preload, increase the cardiac output. So we start giving those positive inotropes. We start giving things like dobutamine to help increase that cardiac output. And then we want to decrease afterload. So we want to have those arteries, those arterial vasodilators. A lot of times these patients will be on mechanical machines such as IABPs, which are intra-aortic balloon pumps, and then VADs, which are ventricular assist devices. For obstructive shock, we want to treat the cause. So whether this is a cardiac tamponade and we need to do a pericardiocentesis, or if it's a tension pneumo and we need to do a thoracentesis, the obstructive, remember, something is blocked. So there is a blocked mechanical obstruction of blood flow, and that's going to cause decreased ventricular filling, which is going to cause decreased cardiac output, hypotension, decreased tissue perfusion, and then impaired cellular metabolism. So I'm just going to kind of hit the high points here, just do a little reiteration of Ms. Fleming's septic shock. So septic shock is a cell integrity problem. It follows the invasion of a host by a microorganism. It's a mediator release stimulated issue. It causes destruction of cells, semi-permeable membranes. It's characterized by vasodilation. We're going to see hemodynamic instability, a maldistribution of blood flow, and decreases in cardiac preload and afterload. So they're going to present initially with decreased blood pressures, pooling in the peripheral tissues, capillary leaking. It's going to cause increased and overwhelming edema. And then we're going to have that decreased ventricular filling, a metabolic acidosis, and then coagulation disorders. So in the early stage, we see that mild hyperventilation, that altered level of consciousness, vasodilation, tachycardia, bounding pulses, normal or increased cardiac output, a widened pulse pressure, and then that warmed, flushed skin. In the late stages, those hypodynamic stages, we're going to see cold, clammy skin, a decrease in systolic blood pressure, tachycardia, those weak, thready pulses, and then respiratory failure. So, treatment and management of shock. So, our role as the nurse, we want to maintain our airway. Obviously, airway is always priority. ABCs. We want to provide supplemental oxygenation or oxygen if necessary. It's super important to get 2 large bore IVs, especially if you're going to have to be mass transfusing a patient, if they've had a lot of blood loss, if they're hemorrhagic, hypovolemic, type shock patient. You probably should just go ahead and put in like 2 16-gauge needles or IVs in each arm because that's what you're going to need to be able to massively transfuse blood and the right amount of fluids into this patient in a very fast manner. So we also want to make sure that their consciousness, that we're maintaining a level of semi-normalcy if possible. If they start having deteriorations and we start seeing changes, those are, problems that we need to address immediately. Skin color, their pulses. If we start seeing external hemorrhages, we want to correct external hemorrhages as soon as we find them, because obviously if we don't, that can ultimately cause death if they bleed out. And then pharmacological management in these patients. So the nursing assessment and the resuscitation phase, we want to provide cardiac monitoring. Remember, if they've had a lot of fluid and blood loss, electrolyte imbalances are liable to be happening. And we can start having EKG changes depending on sodium, electrolyte, potassium imbalances, and things like that. We want to monitor their pulse ox, make sure that they're getting enough oxygen, their oxygen levels are staying up. If they're on a ventilator, we want to monitor end-tidal CO2s. End-tidal CO2s can be indicative and predictive of if a patient is close to, I say crashing, but if they're going to start deteriorating. Foley catheters may be necessary to help make sure that we are not retaining too much fluid, because if we start retaining too much fluid, that's also going to cause problems. What we're putting in once we get that patient resuscitated should be, we should be getting it back out. But once we start resuscitating patients, it may take a second for their bodies to fully get back everything that it needs. But Foley catheters are also really important to determine if we have any urine changes, blood in the urine, things like that. Gastric tubes, if they aren't contraindicated, a lot of the times when we intubate people, we will drop those OG tubes next to their ET tubes so we can give medications, we can give food if needed. We also want to administer those isotonic crystalloids. So LR is preferred just because it has more like electrolytes and things like that in it that will help those patients. But I've also seen saline given as well. We want to make sure we're assessing their vitals, making sure that we're documenting GCSs, and then keeping up with their urine output. But just remember, just because we are monitoring their urine output, it is not a reliable endpoint for adequate resuscitation for shock patients. So if they have a decrease or increase in urine output, it's just urine output is not a reliable endpoint for resuscitation. All right, so resuscitation goals and hemorrhagic shock. So we obviously want to control the source of bleeding. We want to maintain adequate oxygenation and ventilation, restore that intravascular volume that we've lost, and prevent that prolonged hypoperfusion, maintain that normal temperature, and then monitor and support blood clotting functions. So remember, hypovolemia and hypothermia. So when we lose a lot of volume and we're cold, we don't have a normal body temperature, it increases our risk for those blood coagulopathies. So these patients really need to be monitored. So this is a picture Miss Mata had in here. So sometimes people, and you can see her leg over here, how discolored it is, and even this massive gash. I don't know where she found these pictures, but they are kind of gruesome, but very much what you could see in a trauma bay. If you have patients who have pelvic fractures, you may see these like sheets tied like this to help bind their pelvis together until they can get them to an OR, just to try to help prevent as much blood loss as possible and help stabilize that pelvis. Okay, so when we are resuscitating our patient with fluids, our goal is to support the cardiovascular function. So we typically use those standard fluids, LR and normal saline, but the pitfalls can be that overzealous administration can limit that oxygen delivery. We can have transfusion reactions, and then we can have that coagulopathy. So big thing is if we give a patient too much fluid, so say they've lost, all this blood, they've lost blood and they need blood. If we only really replace it with fluid, they need blood. So fluid can't replace blood once you get to a certain degree. And these patients, their blood can become too thinned out, and it can cause even bigger problems. So that's what it means by the overzealous administration can limit that oxygen delivery. Because if we start thinning out the blood too much and diluting it, we're ultimately inhibiting that oxygen delivery. So obviously it's no known thing that blood products, the pool for that is shrinking. So we do have some blood substitutes. They don't require cross-matching. They have a lower viscosity, a longer shelf life. They're not immunosuppressive, and they don't really have any risk of bloodborne pathogens because it's not actual blood. TXA is the most common one. I haven't ever given TXA. I've always only ever given blood, but I also haven't ever worked in just a very rural area to where my supplies may be limited either. Okay, so fluid management and hemorrhagic shock. So peripheral vascular access. So I said earlier, those large bore 16 gauges or higher and bilateral ACs or up. You've got to have big bore accesses to be able to slam fluids and blood products into somebody in a very, I'm talking in 2 minutes, 2 to 5 minutes, slamming stuff into people because we don't have time to wait when it comes to these circumstances. We want, if we have central venous access, this can be in our femoral area, it can be in our subclavian, our jugular, and it's usually an 8.5 French or a 9 French. This is very common with cordis patients. And a cordis is just a type of line. St. Bernard's uses them, and I think NEA does too, a lot in their cardiovascular surgery patients, so their CABG patients. They're big, thick, and white, and when you pull them out of their neck, they literally look like a straw. They're very, very fat. In emergencies, we also can drill into somebody's bone. It's called an intraosseous or an IO, and it's usually kind of done in the knee area or in the kind of shoulder area on the side of the arm. This is especially important with pediatric patients. Sometimes they can be harder to get access on. When in doubt, I've had to IO people before too, like adults, just because I don't have anything else and we can't get anything. If somebody's too hypovolemic, you're probably going to have problems because they just don't have anything really circulating. So when in doubt, IOs are the way to go. So a hypothermia diagnosis is best reflected via a core temperature. A lot of the times you'll see core temperature is, the definition is a 35 degrees Celsius or lower. So those consequences of hypothermia can include an increased oxygen consumption that's going to lead to alterations in metabolism of drugs. It's going to cause coagulopathy problems, can cause cardiac arrhythmias, myocardial ischemia, and it can also increase the risk of wound infections. So with these patients, a lot of the times you will see maybe their Foley catheters have a temperature probe on them, or we drop a temperature probe. I've dropped them next to their ET tube, so they're sitting more like in their core, further down. It's not just like an out, like under their arm type of thing. You can also do rectal temperatures, and those are very, very common in ICU patients. It's just a thin probe, and you just tape it to the side of their bottom and hook it to the monitor, and you have a core temperature 24/7. So we really, really want to monitor their hemodynamics. So if their hemodynamics get too low, if they get too off, it can cause even worsening inadequate perfusion. We want to monitor their lactate levels, because their lactate levels ultimately tells us how bad the shock is, no matter what the cause. And then we can use pulmonary artery catheters to monitor them as well. So if it's decreased, they're usually hypovolemic. If it is greater than 17, their pulmonary artery pressure is greater than 17, it's indicative of pulmonary congestion. And then once we start getting greater than 25, it's indicative of pulmonary edema. So cardiac output, that pharmacological support, we've got those chronotropic drugs we can give, the dysrhythmia agents. Bradycardia and neurogenic shock may require atropine. So, and I know you guys have probably talked about atropine with ACLS protocols. Atropine is going to increase that heart rate, which is going to increase that cardiac output. Those chronotropic drugs, I think of dobutamine is the one that I think of first, and it's going to help increase that cardiac output in those heart failure type patients. With preload, that is going to be your hypovolemic and distributive shock. So we can do what we call an IV fluid challenge. So we can lay the patient flat, or have them sitting up, and then lay them flat and put their feet immediately above, or their legs immediately above the level of their heart. So like hold them up in the air for a little bit. And then if their blood pressure and everything gets better, then that means that they are likely to be responsive to fluid. They need fluid. Cardiogenic shock, we're going to use those venous vasodilators. Afterload, with distributive shock, we're going to want to vasoconstrict. So we want to drive that blood pressure up. Cardiogenic shock, we're going to use those arterial vasodilators. So distributive shock, you're going to see your pressors. Cardiogenic shock, if we're wanting to vasodilate, we're wanting to keep everything down. And then contractility with cardiogenic shock, like I said, dobutamine, it's also going to help with that output and then the contractility of that heart. And then beta blockers are contraindicated in a shock patient. And then resuscitation endpoints. I know I've talked a lot about urine output, but heart rate, blood pressure, and urine output are no longer utilized in isolation to determine tissue oxygenation. The better measurements are our SpO2 levels, so those mixed venous blood gases, those plasma lactate levels, base deficits, and then pH levels. And these need to be trended over time to make sure that we are kind of maintaining, or what we're doing, if we're getting better, if we're getting worse, if we're maintaining, they need to be trended. Okay, and then anaphylactic shock. So anaphylactic shock is obviously just something that, we're all probably very, very familiar with it. It's something that you have an allergy to, that your body releases histamine and it just reacts. So it can be to a drug, it can be to a food, it can be to, snake bites, bug bites, things like that. So antigen sensitization goes to antibody formation, which goes to an allergic reaction. So the classification of allergens and anaphylaxis, we've got injections, we've got drugs, antibiotics, aesthetics, vaccines, contrast dye, iodine specifically, and then transfusion reactions. For ingestions, we also have drugs that can be antibiotics, or this is where our food allergies start coming into play. So, soy, milk, oranges, bananas, shellfish, nuts, beans, egg whites, things like that. And then bites and stings, snake bites, and then insect bites like bees, wasps, and hornets are the most common ones. So when anaphylaxis happens, we get an increased capillary permeability, which causes fluid shifts to go out of the vascular space. Edema happens, and then we have a low cardiac output. So our smooth muscle contracts, we have bronchoconstriction, and then respiratory distress also ensues. And I'm sure if you've ever seen someone or watched a movie with someone who has a anaphylactic reaction, they'll get stung by a bee, or they'll be exposed to, something, peanut butter or peanuts or some kind of nut that they're allergic to. And then they'll start, wheezing, their throat closes up, they can't breathe. And that is a true classic anaphylactic reaction. So our goal here is to restore tissue perfusion and restore adequate tissue oxygenation. And then this is just a response to fluid resuscitation that I talked about earlier with like the fluid challenges and stuff that I left in there for you guys. And then this is our central venous pressure response to fluid. So a minimal rise in initial low CVP with fluid suggests that we need further volume, and it's minimal to no response. A declining CVP suggests that we have an ongoing fluid loss. We need for more fluid or blood, and this is a transient responder. And then we have abrupt or persistent elevation of CVP. Suggests volume replacement is adequate or too rapid, or cardiac function is compromised. So those elevated CVPs, if we've got a heart failure patient already, then we're going to have problems, probably if we resuscitate them too fast, because it's going to fluid overload them. Okay, and that is it. If you guys have any questions, please let me know.